My name is Axel Grothey. I'm a GI medical oncologist at West Cancer Center and Research Institute, and it's a great pleasure for me to talk to you about the management of HCC, hepatocellular carcinoma, with a focus on systemic therapy. Now, HCC is a huge global problem in terms of healthcare resources and mortality. By 2030, we expect 1 million deaths per year, and as you can see, on the slide here, there are geographic differences in terms of incidence, prevalence, and mortality. And I want to focus on the right lower part of the slide, actually, which is interesting. Because you can see here, it plots the numbers of cases on the y-axis to the number of estimated deaths in the x-axis. And when you put a line through this whole graph, that really looks at how many patients will that get diagnosed with a certain disease will eventually die. Any disease that's closest to the line means high mortality, meaning in liver cancer, for instance, here, almost every patient who gets diagnosed with liver cancer will eventually die from the disease. You can see this is very different for outliers like breast cancer in the upper part of the slide, where you have a high incidence, but a relatively comparatively low mortality. Prostate cancer in similar ways. So this can this should highlight that diseases like liver cancer, esophageal cancer, pancreas cancer, very close to the line here, have a very high fatality rate, lethality. And the importance of liver cancer, HCC, is also highlighted by the fact that its incidence and its relative importance in the United States is rising. You can see here the prevalence of these different cancers in terms of mortality in the United States over time. And liver cancer will move from a lower rank to number 3 in 2040 due to a lot of environmental factors, including the higher rate of steatohepatitis due to obesity in our patient can see. On the other hand, another milestone that will happen is that very soon, in the next 2 years, pancreas cancer will be number 2 in mortality in the United States and will be kind of crossing over to colorectal cancer. So we'll have lung cancer and pancreas cancers, the top 2 cancers in the United States in terms of mortality. Now, the etiology of HCC, hepatocellular carcinoma, varies across the different world, the contributions of the etiology. We know that alcohol use, the viral infections, hepatitis B and hepatitis C, and also the NASH, non-alcoholic steatohepatitis, obesity related mainly, contribute to the development of liver cancer. And see, for instance, in the United States, it's still mainly hepatitis C that really drives the etiology of liver cancer, whereas in Eastern Europe, for instance, it's a lot of alcohol use. And in Eastern Asia, outside of Japan, it's hepatitis B, which we know is preventable and we can vaccinate, and hepatitis C, on the other hand, can also be treated. So these are things we need to take into account when we also look at the different outcomes in terms of treatments in different regions where trials are being conducted, because the etiology of liver cancer differs. Now, important points to consider right up front: HCC commonly arises in a diseased liver. We have inflammation, we have cirrhosis, steatosis, and these factors impair liver function and create a low functional reserve of the liver, so that surgery can be difficult. And sometimes we have to treat the underlying etiology. We already talked about hepatitis C. It also provides a rationale for liver transplant, because you not only take the cancer out, but also the underlying disease, I mean, liver cirrhosis, for instance. And, of course, decreased liver function is important for treatment decisions, because a lot of our treatments actually require so-called healthy livers, or at least somewhat intact liver function. And then on the other hand, liver cancer can present as a local liver-only disease for a prolonged time, and that provides the rationale for local regional therapies like ablation, microwave radiofrequency, PACE and TARE, where we use the arterial supply through the hepatic artery to tumors for chemoembolization, radioembolization. We have a lot more data on chemoembolization, actually, and also, of course, liver transplant. And management of HCC definitely requires a multidisciplinary MDT approach. So to assess the functional reserve of the liver, there are different scores, and you're probably familiar with the Child-Pugh score on the left-hand side. The MELT-NA score gives you kind of the mortality in the near future. And all these can be accessed by online calculators. And it's very critical that we document the MEL score and the Child-Pugh score in our patients' records, because it does influence the availability of treatments and actually also how patients are being ranked for instance, liver transplantation. Now, if you want to have one slide on my presentation that you'd like to print out and use for reference, is this one, a very new update in Journal of Hepatology 2022 about the Barcelona Clinic liver cancer staging. And it's not just staging, but also the accompanying treatment modalities that you can use from very early stage to early stage A, intermediate stage B, C, which is more advanced stage, where we use systemic treatment, and a terminal stage where only best supportive care is being used. You can see different treatment modalities. I will not address a lot of those listed for the local regional therapies. I'll focus on systemic treatment more to the right-hand side. But I want to spend a moment on liver transplant, because that is some of those modalities we normally do not always think about. And there are clear criteria for liver transplantation. The early criteria were developed in Milan, in Italy, and you can see the criteria selecting patients with relatively low disease, low volume disease for transplant. And these criteria have recently been expanded with other scoring systems. And you can see here that the outcome is actually pretty good for these patients. 5-year survival rate in the range of about 70% when you really are a candidate for liver transplant, which clearly beats other treatment modalities. Now, let's focus on systemic therapy. And before 2019, where we really embraced the immunotherapies as first line, there were various different treatment options: sorafenib, lenvatinib, in second line, regorafenib, nivolumab, pembrolizumab as immunotherapies, cabozantinib, ramucirumab, and then cabozantinib in the third line setting. And I want to go quickly through some of the data. And I'm a visual person, so I like these survival curves and not tables that really highlight, the difference between treatment approaches visually. So let me show you, for instance, what really made liver cancer a disease that medical oncologists actually see and treat: sorafenib versus placebo in first line. In 2008, we could still conduct trials with a placebo in first line because we really didn't have any treatment option. You can see here, sorafenib versus placebo. The curve with sorafenib is way on top of the placebo curve with a hazard ratio of 0.69. What's hazard ratio? It means the actual benefit of the treatment over the whole context of the conduct of the study. It means a 31% reduction of death events on the study. It is a much better measure of the efficacy of a treatment compared to median, which really only represents one patient on one curve and one patient on the other curve at the 50% margin. So look at hazard ratio, 0.69, that's a strong hazard ratio, minus 31% mortality. And in Asia Pacific, a second study confirming exactly the results of sorafenib. Then there was a study comparing sorafenib to lenvatinib, another kinase inhibitor that we use in various diseases like liver cancer now, thyroid cancer, and kidney cancer. You can see these curves were on top of each other. There was non-inferiority. Lenvatinib beat sorafenib in progression-free survival and response rates. So we commonly use lenvatinib now as part of our first-line treatment. Then we have the first documentation that second-line therapy actually worked after sorafenib, a study that compared regorafenib in second line against placebo, the so-called resource study. And all these studies were actually conducted in a lot of patients, here more than 500 patients. You can see a hazard ratio of 0.61, a 39% reduction of death events on the study when you use regorafenib compared to placebo in a second-line setting. Now, all these patients have excellent liver function, Child-Pugh A. So these are not patients with deteriorated liver function. That's something you need to keep in mind when you interpret all the studies. These patients are highly selected and might not necessarily represent the patient we see in clinical practice. Cabozantinib in a second and third line setting after sorafenib-based therapy before versus placebo, hazard ratio of 0.76. Again, that is clinically meaningful, 24% reduction of death events. And about a third of these patients have been treated with 2 prior lines of therapy. Then ramucirumab, an antibody against VEGF, vascular endothelial growth factor, one of those angiogenesis factors, against tests against placebo in patients with high AFP, alpha fetoprotein. They have poor prognosis. You can see here hazard ratio 0.71, meaning a 29% reduction of death events. So all these things are available and clinically meaningful. And then came the era of the immunotherapies. Because, you know, we know every drug that I've shown you so far, sorafenib, lenvatinib, cabozantinib, regorafenib, they're all multi-kinase inhibitors. They have side effects, skin reaction, hypertension, diarrhea. So they're not necessarily very well tolerated in our patients. And we struggle sometimes keeping patients on these treatments for a long time. Immunotherapy has much better toxicity profile, and we commonly use nivolumab and pembrolizumab as PD-1 antibodies. And the initial data that we saw were single-arm phase 1/2 studies, which just treated patients without comparison arm. We saw that we had response rates in the range of about 15%. These were the first documentations in 2018 that these drugs might actually have activity in HCC. Now, comparison studies, meaning pembrolizumab, for instance, here in the second-line setting after sorafenib against placebo, were more difficult to interpret because the first study that we saw, Keynote, all the Keynote studies on pembrolizumab, the Checkmate studies on nivolumab, the Keynote 240 study, which compared pembrolizumab in second-line therapy against placebo. It should have worked because we know these drugs have activity, but based on the statistical calculation was considered negative in spite of the fact that the response rate was higher. And when you look at these curves on the left-hand side, overall survival, right-hand side, progression-free survival, I do believe there is a difference, but from a statistical perspective, these studies were considered negative. But the NCCN guidelines actually adopted these data still and looked at patients who were not necessarily considered candidates for sorafenib or lenvatinib, the kinase inhibitors, and actually recommended the use of pembrolizumab in patients. Now, a second study, which also was supposed to be positive, but was negative, was nivolumab versus sorafenib in first line. So here is a large trial, 740 patients, and you know, sorafenib is kind of the low bar of comparison now in first-line treatment. And unfortunately, there was really no statistically significant difference, not even a, I think, meaningful clinical difference between these two arms. So nivolumab didn't beat sorafenib. Now, then the Embrace 150 study came around, and I want to spend a little bit more time on it because it did set a new standard of care that we're currently using. This was, again, first-line treatment, sorafenib as control arm. Now, combination of atezolizumab, which is a PD-L1 antibody, plus bevacizumab as the experimental arm, 2-to-1 randomization. These patients, again, were good patients in terms of Child-Pugh A patients. All had been screened with endoscopy for the presence of varices because there was the idea that bevacizumab could cause some bleeding of varices in these patients. So varices had to be excluded or treated. And, you know, the study was positive. First time that we had an immunotherapy study beating sorafenib in first line, and actually with a very meaningful difference. Hazard ratio of 0.58, a 42% reduction of death events. And if you really like to look at medians, you know, median overall survival for atezolizumab was not even reached when the study was published in the New England Journal of Medicine about 2 years ago. And so this was really set a new standard of care. Now, this is so-called forest plot. It shows you are there subgroups of patients that might not benefit. And, you know, the line, the kind of red line is kind of where if a dot is on this line or close to the line, there's no big difference between atezolizumab, bevacizumab, and sorafenib. You can see, for instance, that BCLC, the Barcelona Clinic liver cancer, stage B, intermediate risk tumors, they did not necessarily benefit from atezolizumab, bevacizumab. But most importantly, what I want to show you is that non-viral HCC does not appear to benefit as much from immunotherapy. And that's been shown consistently now with other studies. So those patients might still benefit from lenvatinib and sorafenib even in first-line therapy. So non-viral versus viral HCC, different response to immunotherapy. Now, progression-free survival, how long it takes for patients to show progression events, again, a big difference here between these different curves. Response rate was higher, 27% compared to 12%. And in liver, there are different ways to look at responses, kind of normal shrinkage of tumors or some imaging characteristics. But however we looked at the data, atezolizumab plus bevacizumab beat sorafenib hands down. Now, important, of course, in this patient population is also toxicities from therapy. And I like the way this here is presented. You can see this comparison plot, atezolizumab, bevacizumab on the left-hand side, sorafenib on the right-hand side. The longer the bars, the more intense the color, the more side effects we have. And just visually, you can see that atezolizumab plus bevacizumab has a better toxicity profile compared to sorafenib. And we also have patient-reported outcomes data, quality of life data, showing that this combination of a bevacizumab VEGF inhibitor plus atezolizumab, a PD-L1 antibody, has a better impact on quality of life. It takes longer for patients' quality of life to deteriorate compared to sorafenib. And I think this is one of the critical points, of course, in our management of patients. So we have data in terms of overall survival response, progression-free survival, and quality of life, all supporting the use of atezolizumab and bevacizumab in first-line treatment. Now, I told you that patients with bevacizumab might have issues with varices, so what about if we have a combination treatment that just uses immunotherapy? This is the so-called Himalaya study, which was published this year in New England Journal of Medicine Evidence. It's a new journal that they came out with, again, patients with intermediate risk or systemic, high risk stage B or C, all with good liver function, Child-Pugh-A. They're randomized in 3 arms: durvalumab, which is a PD-L1 antibody, with or without a CTLA-4 antibody, similar to ipilimumab that you're probably familiar with in different settings. And tremelimumab was only 1 dose to prime the immune system before durvalumab then has more tumor-specific activation of the immune system. This was called the so-called STRIDE regimen. This was all compared to sorafenib. So the comparison was durvalumab, single agent versus sorafenib, or durvalumab plus tremelimumab against sorafenib, but not a comparison between the 2 experimental arms. Now here are the data. You can see, first of all, on the lower part of the slide to the right, response rate was higher with the STRIDE regimen, so the combination of tremi and durva, and with durva alone compared to sorafenib in first line. But also there was a difference, what they call statistically significant, and I believe clinically meaningful difference in first line treatment with both STRIDE and durvalumab. You can see the hazard ratios in the table: 0.78 for STRIDE, which is strong, 22% reduction of death events, and durvalumab a little bit attenuated, hazard ratio of 0.86. So in doubt, if you can, STRIDE is better than durvalumab single agent. But as you can also see in cross-trial comparison, which we always like to avoid but always do, we see that atezolizumab, bevacizumab still is probably the more stronger regimen. Now, not everything works when we in HCC in terms of immunotherapy combination. We had data actually from lenvatinib plus pembrolizumab, 2 drugs which work in HCC individually. And there were initial data in more than 100 patients with a very nice waterfall plot, which shows the response rate of this combination. You see a lot of patients actually had an excellent response, and going down to 100% response rate here, complete responses in patients. But in a comparison with lenvatinib, was just shown a couple of days ago, actually at ESMO 2022, lenvatinib versus lenvatinib plus pembrolizumab, the study was negative, and so it will likely not move forward for approval. So where are we right now to sum things up? I showed you the slide earlier where we started with sorafenib and lenvatinib, and now we have a kind of a -1 line of therapy, either atezolizumab plus bevacizumab or durvalumab with or without tremelimumab, particularly for those patients who might have contraindications against bevacizumab, talk about the varices. There's a combination up front. We still have the kinase inhibitors, sorafenib, lenvatinib, regorafenib, and others here, and they might be candidates for might be good options for patients that have non-viral HCC. And nivolumab actually was taken off the market as single agent. This is no longer being used. And so to conclude, atezolizumab bevacizumab is the current standard of care in first-line treatment of patients with unresectable HCC. You need to keep in mind, there's an inclusion criteria for these patients. So autoimmune disease, history of, liver transplant, for instance, and the varices that we talked about need to be taken into account. In EGD, in this trial, was mandatory for patients, and they were only patients with Child-Pugh A. There's an unmet need for patients with Child-Pugh B at this point in time. The durva-tremi data are alternative treatment options for first-line patients have a contraindication against bevacizumab. And multi-kinase inhibitors and ramucirumab have kind of shifted down the line, but they might still be first-line options in the HCC of non-viral etiology, as I mentioned. And again, to highlight, beware of immunotherapy in liver transplantation. Obviously, this is not a good idea to activate the immune system in patients that that had undergone a liver transplant. Thank you very much.